And then share screen. And then we can hide these.
Start thinking about this. Yes. I have put you on the-
Will this be in your way or is
No,
that okay?
I think this is all right, and then I can just click through when we're ready for new slides.
Yeah.
Oh, I think this
Does
should
that
be,
work?
yeah, this should be fine. I'm very low key.
Okay. All right. Perfect.
Yeah.
Okay. We'll get started then.
Sounds
All right, you
good.
guys, we're gonna get started. This is Caitlin.
I'm Caitlin. Thank you for having me. This is nice of you to want to hear about our service. I'm one of the, I work on the inpatient team. I'm a nurse practitioner on the OTO Blue service. So I was asked to come speak with you today. I'm going to talk a little bit about our service, kind of our patients in general, kind of the post-op picture and kind of where they go. It's a huge topic. I tried to make it as concise as I can. So I'm just going to kind of briefly go into this. And if there's any questions at the end, I'm happy to answer. Or if you ever want more anything more detail, I'm happy to come back and we can talk about something more specifically at other times if you like. But for today, I'm just going to try to give a broad overview of our service and kind of what you might see coming out of the PACU and then what happens to them through the hospital and beyond after that. So we'll get started. So like I said, I work on the OTO Blue service. We have a few OTO services just because our department is so big. And I work on the inpatient side on the OTO Blue team. And our team, we primarily take care of the head and neck cancer patients. Those are the big ones that you're going to see coming onto the OTO Blue service. And we also take care of patients who are being treated for a complication of their cancer treatment or a sequela of their disease. So we'll see a lot of that. We also take care of patients with other airway abnormalities, arteriovenous malformations, some benign conditions that might require like a thyroidectomy or a parotidectomy. So you'll see some of that. We'll get like a variety. We also do a lot of complex reconstruction on our service. Some of the reconstruction that we do is related to cancer treatment. Some reconstruction that we do might be related to a trauma that a patient had, gunshot wounds, or burn or motor vehicle accidents, things of that nature. So you'll see a lot of big reconstruction on our service as well. We have a pretty big team. We have 6 attendings on our service. We collaborate with other attending surgeons within the OTO department, but the main ones that you'd see on the Blue service, I have listed up here. You'd probably recognize a lot of their names. We have 2 head and neck reconstruction fellows. They do a 1-year fellowship. So our Dr. Yin and Dr. Winden just started with us in July, and they'll be here with us through next summer. And then our team, also, we have a group of residents. They rotate through the Blue service every 3 months. We get a new group. So you'll see lots of faces. And then there's myself and Marie Laginza. She's our other nurse practitioner. And we primarily work on the inpatient floor, but every now and then we'll kind of pop through. You might see our faces if we're looking for a patient or one of the docs. We might kind of float around the area a little bit, but we're primarily up on the floor. And then of course, there's lots of nurses and techs, and we work very closely with speech, social work, PT, OT, our care managers. We're a very multidisciplinary department. We work with a lot of specialties. So kind of going into, how the patients get where they are, they'll present to us through the clinic. A lot of our patients are referrals from smaller outside hospitals or local, small local clinics, that don't have the capabilities to be able to treat the patient the way they need to be treated. So they'll get referred here to us. So they'll come see us in the clinic. We'll do a full physical exam. We'll get any additional testing or imaging or lab workup that needs to be done. And then once we kind of have an idea of what we're dealing with, the patient gets presented at our tumor board. Then that meets with radiation oncology, medical oncology, and our surgeons. And we kind of come up with what might be the best treatment for a patient. And if surgery is the route that we're going, they'll come back. We'll have a surgical planning clinic appointment. We'll have them meet with our gen med to get a pre-op evaluation. And a lot of times that's done here. Sometimes if a patient lives far away, they can get that done closer to home. And so then once we have surgery booked, they come in, they get their surgery here. They'll see you all after the case, and then they get admitted to the floor. And I'm going to go into a little more about, what the inpatient course looks like. But of course, depending on what was done, the length of stay varies and all of that. And then we'll discharge them home, whatever's appropriate given their course. A lot of our patients go home with the support of a visiting nurse. Sometimes with the hospital care at home program, we'll set them up with that if that's appropriate and they're eligible for it. And then a lot of our patients end up going to subacute rehab or an LTAC for a period of time before going home. I'm going to kind of briefly review head and neck cancer. Just in general, this is it's a huge topic. To briefly review, it's head and neck cancer. It's categorized into the subsite or region where the cancer arises. So you'll hear phrases like oral cavity carcinoma, oropharynx, larynx, hypopharynx. Those are all sites of cancer. And then it gets even further categorized into subsites. So you might hear like squamous cell carcinoma of the left lateral tongue. That's the most specific way to say it's, in the oral cavity on the left lateral tongue. So that's how we describe cancers. Most cancers of the head and neck arise in the squamous cells, which are the small little cells kind of in your mucosal tract, mucosal membranes. And they line the respiratory, upper respiratory tract and the aerodigestive tract. Risk factors for head and neck cancer, the big ones we see that are really going to increase your risk are cigarette smoking, heavy alcohol use, and HPV. Those are some of the big ones. In Southeast Asia and in the Pacific Islands, betel nut chewing is another risk factor for head and neck cancer. But we don't see that as commonly here in the US. That's kind of what you're going to see around here. Signs and symptoms. The big ones are pain, pain in the mouth, pain with swallowing, pain in the ears, especially pain on one side of the ear or another. A lot of patients will present to us with a neck mass. A lot of patients will go to their primary care doctors with some sort of symptom or complaint, and they will be prescribed a course of antibiotics, and their symptoms don't get better. And then they come to us and it's sure enough cancer. The current guideline is that if a patient presents to a PCP, an adult patient presents to a PCP's office with a mass in the neck, it should be presumed as cancer until proven otherwise. So it's something to be taken very seriously. It's something not to miss. And then we kind of go from there with the workup. I think that's what I wanted to say on that slide. All right, so the treatment for head and neck cancer, it varies based on, the stage at presentation, the site, the patient's functional status at presentation. But the mainstays of treatment in head and neck cancer are surgery, radiation, chemotherapy, or immunotherapy. It's our job when the patient comes to the clinic to kind of talk about what the standard of care is for the specific disease the patient presents with. But the decision of how to treat and what to do next, it's really a collaborative decision between the patient and family and the surgeon as well, because, some of these people have preferences. These surgeries that we do are humongous and they're life-altering and life-changing, and they're not easy surgeries to go through. So having a discussion about goals of care and what's important to the patient is really crucial when deciding how to treat these cancers. Yeah, I know. Yeah. So this is a question we get a lot. I will say, so I used to be a nurse on 4B before I became an NP and I got this job. And I used to think like, oh my gosh, do they not talk to these patients at all? Like, has anyone actually even read a basic consent form with them? Like, I used to think like, this is no way. the truth is, yes, the patients they are definitely informed. A lot of our patients actually meet patients who have gone through this prior to their surgery. They'll meet other like laryngectomy patients or something. They also meet with our speech language pathologist prior to surgery to discuss it. One thing that we are hoping to do, we don't have the staffing for it right now, or the bandwidth to do it, I should say, we used to do pre-COVID, we would have patients come up to 4B and do a teaching with the nurses to kind of go into even more detail about everything that was going to be done. But the staffing situation is just everywhere. And, Marie and myself, we don't have the bandwidth to do it, but in the future, we'd like to kind of get that up and running again, even more pre-op preparation. But I think the reality is that you can hear all of this stuff. You can hear it so many times. I think when you're getting big news, you only absorb about 50% of it. You have to hear it several times. And I think even then, I don't think that can totally prepare you for the shock of losing your voice or waking up breathing through your neck. It's a lot to go through. So in short, yes, they are prepared for it. Like, it's a discussion and risks, benefits, and the whole thing is explained to them. But I just think you can only prepare so much. It's a big shock when you wake up, and I don't think you can really be prepared till you're going through it. The other thing is, I think you have to also kind of balance with patients, discussing the risks of surgery and being realistic with them, but also giving them hope too, that in the end, it's going to be rough for a while, but we can get you through this and you can actually live a very normal quality of life, very good quality of life, and you can do anything you want to do. And it's a hard balance, but I know I get where you're coming from, because I too used to think no one talked about this with them, but they do. I promise you they do. Okay, so I'm going to go into a few of the surgeries that we see, and you can stop me at any time. I'm happy to talk about this all in more detail. This is a huge topic, but some of the big ones that you'll see, and you've probably all seen before, is the neck dissection. This is a surgery. It can be done alone. It's done in combination with a lot of bigger resections. The purpose of a neck dissection is to remove lymph nodes that are either known to be high risk for cancer or ones that already have known disease. And it's to assist with staging and also decrease the risk of further disease spread. So, depending whether it's done on its own or if it's in combination with a larger surgery, on its own, a neck dissection is usually about a 1 to 2 day length of stay in the hospital. When you're in the hospital, we're going to watch your incision. We're going to look for signs of infection. We're going to watch your drain output. Typically, these patients come out of the OR with, 1 or 2, sometimes more drains. We try to get out a few of the drains before leaving the hospital. Oftentimes, a patient will go home with at least 1, sometimes 2 drains. So the nurses up on the floor do a really good job. They teach the patients how to care for the drains at home. They teach them how to care for their incisions. And those are the big things to watch out for. Hematoma is another complication that you'll see sometimes of a neck dissection. Sign of that, you would see firm swelling of the neck. Sometimes a patient will say they're having a really hard time breathing. That can be a sign of a hematoma. It's something really to take very seriously. If any of these patients wake up having a hard time breathing and their neck is really swollen and the drain output is really dark sanguineous drainage, those are signs of complications you'd want to let us know right away. The other thing we do with these patients, we consult physical therapy for all of them to come post-op day 1, just to give them some neck and shoulder range of motion exercises. The cranial nerves sometimes get stunned or altered during these cases. And so we want them to, move their shoulders and move their neck so they don't get stiffness and a frozen shoulder down the road. So we always have PT see them once before they leave, and then they typically can go home in 1 or 2 days if it's just a neck dissection. Okay, the next one, thyroidectomy. You'll see this a lot. The main indications for a thyroidectomy, this is the removal of the thyroid gland, sometimes plus or minus the parathyroids around the thyroid, is if there's a cancer. If there is a mass that's causing compressive symptoms like difficulty swallowing or difficulty breathing, Sometimes for cosmesis, if the mass is so large, it can be bothersome to the patient, or failed medical management of a hyperthyroid condition. Those are some indications for taking out the thyroid gland. The recovery of a thyroidectomy, typically, like in a thyroidectomy alone, the length of stay, it varies depending on the extent of the resection, but generally speaking, it's about 1 to 2 days. The big things you're going to watch for after a thyroidectomy, similar to the neck dissection, you're going to watch for swelling, pain, infection. Hematoma and infection are a big risk of the surgery. But the other thing that's really important to know about a thyroidectomy is watching the calcium levels in the patient, especially if the parathyroids were removed as a part of the case. So you'll see oftentimes that our residents will want you to check a PTH in PACU, calcium levels. We watch calcium levels generally about every 8 hours until they stabilize. We'll start you on a pretty aggressive calcium regimen, and then kind of taper off as needed. So signs and symptoms of hypocalcemia, which is a big complication of thyroidectomy, would be like numbness and tingling around the lips or in the fingertips. Generally speaking, when a patient has those symptoms, their calcium level is pretty low, and that can put them at risk for other cardiac complications. So we tell them to take an extra dose of their calcium medication and call us if they're at home. We'll want to get their labs checked right away. We might have to make some adjustments to their regimen, but that's a big thing to watch out for. The other thing is with these thyroidectomies, you know, a lot of times they'll do monitoring of the recurrent laryngeal nerve during the case. So, you know, difficulty with breathing is not generally an issue afterwards, but sometimes that recurrent laryngeal nerve can get stunned. And if the patient wakes up and they're having a hard time breathing, there's a risk for vocal cord paralysis. So you want to be just cognizant of that as well. But of course, if any time a patient's having a hard time breathing, you know, we'd want to know about it. Okay, parotidectomy. So this is the removal of the parotid. I promise I have pictures of more fun things later in this presentation. This is kind of dry, but some of the big ones you'll see here. Parotidectomy is the removal of the parotid gland, which is one of your major salivary glands. So if there's a parotid mass, either benign or malignant, we can take out the, we'll take out the parotid gland. Sometimes if there is a skin cancer that extends into the parotid, they'll do a wide local excision of the skin as well as the parotid to take that out. And depending on how large the resection needs to be, you can either just do a parotidectomy. Sometimes you'll see a big flap, big cutaneous flap parotidectomy. And the post-op care is essentially the same as the thyroidectomy and the neck dissection. You're going to watch for infection, hematoma, things like that. JP drain output. So the nurses, again, they do a really good job teaching all of this up on the floor, drain care, incision care, and then going home in about 1 to 2 days. Complications for this are a little different. Again, infection, hematoma, all of that, but you might hear, or you might see in a risk factor, first bite syndrome or Fry's syndrome. When the salivary glands removed, first bite syndrome is pain with eating. After the parotid gland's been removed. Sometimes it's permanent, sometimes it goes away. It's something that can be addressed in the clinic down the road. We recommend a lot of times like doing like mouth rinses or like sucking on hard candies, things like that can sometimes sort of help. And then Fry's syndrome or gustatory sweating, that's sweating with eating. Those are other complications or risks, I suppose you could say, of a parotidectomy. Okay, so these are some of the bigger ones. Now I'm going to get into more of the bigger stuff you'll see and kind of talk in more depth. And this is, again, a very vague overview of an oral cavity resection. So oral cavity, that's the oral tongue, the retromolar trigone, the buccal cavity, the gingiva, the gums, and the lip and the hard palate in the front of the mouth. And again, depending on the size of the mass, the resection might be small, it might be something that's able to be closed primarily. A patient might discharge as an outpatient. They might stay 1 to 2 nights. Or if it's a large mass with a larger resection that requires a free flap, they're usually in the hospital for about 4 to 7 days or so. Also, kind of depending on the size of the mass and the resection, sometimes we allow patients to start eating and drinking or having small sips of fluid right away. Sometimes it requires a feeding tube for a couple of weeks post-operatively, but it all kind of depends again on the extent of the resection. So post-op care, the big things the nurses are really good at oral rinses and teaching the patients how to do their mouth rinses appropriately. We do them about every 4 hours or so until they come back to see us, and teaching them how to use a feeding tube and kind of going from there. And then the oropharynx, that's more of the back of the mouth. It's the tonsil, soft palate, and the base of tongue. And again, it all depends on the size of the resection. If it's something small, you might see the robot being used, the TORS resection. And that can be a patient, that's generally a few day length of stay. I find that patients that have had a TORS resection, they have incredible pain, like a TORS tonsil. It's very, very painful in an adult. So pain control and good oral intake is so important in those patients. A lot of times they'll get a feeding tube placed temporarily after surgery because it's so hard to maintain adequate nutrition and hydration without it. Some patients do fine, but anecdotally speaking, it's a pretty painful procedure. So a feeding tube is placed so they can get pain meds and nutrition and hydration. But again, if it's a larger resection, you might see a free flap to fill the defect as well. Okay, so free flap, that's kind of the big thing you'll see on the OTO Blue service. That is a procedure where you're going to take tissue, fat, muscle, blood vessels, bone from one area of the body, and you're going to use it to fill the defect where the cancer was resected or whatever the resection was. It's there's a microvascular component to the surgery to connect the blood vessels. And so when we're checking the Doppler, that's checking the anastomosis to confirm that there's good blood flow to the reconstruction. So things that we check for are capillary refill, we check for color, warmth, and we check the turgor. Sometimes we might poke it to see if there's brisk, bright red blood return. And we check a Doppler signal. So that's those. If everything looks healthy and good, that's kind of how we know that the flap is on track. When the patients are up on the floor, the nurses check it every hour for 2 days, then every 2 hours for 2 days, and then every 4 hours until discharge. Plus, our service comes around and we check the flaps frequently as well. So one of the biggest complications that you'll see initially with these flaps is free flap failure, like venous compromise or arterial compromise, requiring a return to the OR. That generally happens, if it's going to happen within the first 2 to 3 days, is the highest risk time for a free flap to require a return to OR because of the vascular anastomosis. Not to say that it can't happen further down the road. If it happens further down the road, it's generally a complication of an infection or like a delayed tissue failure. But generally speaking, if the flap's going to go down, it's within 2 to 3 days, most of the time. So one of the things that I used to always wonder, and I get asked a lot, is how do you know which flap to do and where to put it and where you're going to go with things. And it kind of depends on what the defect is going to be. If it's a soft tissue reconstruction, something like a tongue reconstruction, you're going to want a soft tissue. So that would be a flap like a forearm or an ALT or a latissimus flap that could reconstruct the tongue or, the inside of someone's cheek or, a floor of mouth. That's all soft tissue reconstruction. If it's something like a mandible, that's a bony reconstruction. The mandible would require something like a fibula flap or a scap flap, something like that, like a bony reconstruction. And so that's how you kind of decide. And then the other part that goes into it too is, what's the patient's functional status? What are their hobbies? What do they do for a living? If it's a patient that, they're a golfer, they might not want a latissimus flap because you're taking muscle out of their back and, that's going to affect their swing. They might be somebody that's better off with an ALT, something like that. So our surgeons do think about that in part, when deciding which tissue site to go from. But of course, it also kind of depends too, where's the best blood flow, where's going to be the healthiest place to transfer tissue from. Most of the time, yes, they have a plan. Like we know we're going to plan for an ALT free flap, but sometimes they might go in and start to raise the ALT free flap, but the vessels are not good. So they'll close it and then they might move to the forearm. Or sometimes what happens is, we're planning to do a forearm flap, but we got in there and the defect was larger than we anticipated and we need more tissue. So we're going to take from the ALT. So they have a general idea. And most of the times the plan goes as anticipated, but sometimes things don't go as planned. They'll oftentimes consent for flaps and grafts as needed. That kind of covers that if they need to take tissue from one area or the other, or sometimes they'll need to take like a vein from another area, like they'll be able to get all of the tissue you need from your arm, but we need a vein. So we'll take a vein from, the lower leg, something like that. That's okay. After what? After perfume? Yeah. You have enough collateral vessels that you can do fine without it. Yeah, that you can do okay without it because you've got other ways for blood flow to get down the leg or wherever. All right, here are some pictures. So these are some pictures. I talk about incision care. This is a really big thing that is really important post-operatively. It gets kind of glossed over because it seems simple, but poor wound care leads to wound breakdown. This picture on the right, this is a skin flap. I think it was a mandibulectomy and with a skin paddle that was done on the outside, but it's a really crusty incision. One of the things you can do if you see incision care like that is to just put tons of Vaseline on it. But you want to be really careful too, because it can lead to wound breakdown if crusts like that sit on an incision for so long. And then this one in the middle, that's an ALT free flap. It's kind of hard to see with the pictures on this, but that patient developed cellulitis. It's pretty red around his incision line. But this ALT on the far left, that incision, that one looks great. There's a little bit of redness. It looks like it's just irritation from the staples, but it doesn't look infected to me. Generally, we do our incision care. It depends on what the incision is closed with. We'll do bacitracin for 3 days, followed by Vaseline until discharge. Some of our surgeons prefer Bactroban, but it's just surgeon preference. Okay, wound dehiscence. This is a complication that we'll also see a lot in any of our surgeries. Risk factors for wound dehiscence. These are some pretty significant pictures. I don't know if you can tell really well, but this one here on the left, that's a neck incision that opened up. You could pack right into her neck. And then this one on the right, that's a picture of a forearm that dehisced. We ended up putting a wound vac on that one there on the right. I think that one on the left, we might have put a wound vac on her too. Risk factors for wound breakdown like this: poor nutrition, especially preoperatively. One thing that I'd like to do in the future is get our patients in sooner. A lot of these patients have poor oral intake preoperatively because they're in so much pain from their cancer and they're not eating very well. So their nutritional status is pretty depleted when they even walk in the door. We're having them work with a dietitian preoperatively would be really helpful, to just kind of bulk them up to help with postoperative wound healing. Poor incision care, uncontrolled blood sugar, hypothyroidism. A lot of our patients have a history of radiation to the head and neck before they even present to us. Radiation to the head and neck, prior history of that, it really wears at the tissues and the skin of your head, of your neck, and that can make for really poor healing. It also, a lot of the patients that have a history of radiation, they have devascularized blood flow to the thyroid gland. And we have found that there's a correlation between hypothyroidism and poor wound healing. So we'll put a lot of our patients on a supplemental. They're already on thyroid supplementation anyways, a lot of them prior to their surgery, but we'll put a lot of them on even additional or high doses of thyroid supplementation post-op to kind of help with some of these complications of wound healing. So you might see that frequently. Not so much maybe in the PACU, but down the road during their hospitalization. Okay, so you'll see in the PACU, the patients come out, they've got a big wound vac, bulky dressing on their arm or leg, wherever their donor site is. We'll put wound vacs on forearm dressings. We'll also put them on fibula donor site dressings. And so those wound vacs, we generally keep them in place for about 5 days after surgery. And then at that point, we'll take them down and we teach the patient how to care for the wound at home. And it's generally a once a day dressing of a xeroform gauze over the skin graft donor site, followed by gauze and a Curlex wrap. And then that dressing, they change it once a day, generally for about 3 or 4 weeks post-operatively, and then we can have them just apply Vaseline. This picture on the left here, this is a forearm donor site, and we took the wound vac off. It actually looks great. Kind of that pinkish purple tissue is exactly what we would want to see. Eventually this will all heal in nicely and just look like regular scarred skin. And then this one here on the left, you can't see it very well in this light, but this is a fibula donor site. It's pretty crusty, this picture, but it otherwise looks healthy. So we apply like lots and lots of Vaseline, but the wound care is the same. And we kind of go from there. I think that's all I wanted to say about that. Oh, the fibulas. So they'll come out of the OR oftentimes with like the air cast boot, that big bulky boot. We tell patients they need to wear that for ambulation at all times until instructed otherwise. When they are resting in bed or in the chair, it's okay to take it off and wear a Lennard boot to help kind of support the ankle and kind of provide flexion of the ankle. But for any weight bearing activity, at least until they're seen at their post-op follow-up appointment, they have to wear those big bulky boots. And then the forearms as well, we get a splint made from occupational therapy. They'll make a splint, usually post-op day 1. They'll make it, and we do it to have the wrist in like a 30-degree flexion like this, just to kind of help support the skin graft so it heals appropriately. And that cast is worn usually about 3 to 4 weeks as well post-op. All right, these are some pictures. I stole these from Dr. Spector. He has some really good ones, so I took from him. This is an oral cavity flap. So the first picture up here in the upper left-hand corner, that's actually a picture of the tumor on his tongue, that little white spot you can kind of see up there. And then this second one is a picture of the flap after it's been inset. And that's what we would see, it looks like that generally throughout the course of the patient's hospitalization. The nice healthy flap there of the left lateral tongue. And then this last picture down here, that's a picture of it once it's healed. So people always like to kind of see what does it look like down the road. You can see the swelling has gone down a lot. The flap has healed in nicely. These patients, they work with speech therapy regularly with our surgeons down the road for as long as they need. Speech is always seen with the surgeon at their first post-op appointment to give them exercises and assess what kind of oral intake they can do. But many of these patients end up on regular diets, within a few weeks after surgery. These are more pictures. This is an oral cavity mandible free flap in floor of mouth. So you can kind of see here, that's the first picture up in the upper left corner is a picture right after surgery, after the flap was inset. And then there on the right, once it's healed up. And this is the leg down here. So there wasn't really I didn't have any great pictures of a leg right after the wound vac's been taken down, but it looks, when a wound vac on a leg is taken down, it looks pretty similar to the forearm dressing site, kind of that purplish gray sort of picture. But as it heals, you'll kind of start to see some slough and kind of look like that. That's what it'll start to look like as it heals. And then you can see there on the right, that's the picture of the leg after it's completely healed. Almost. I would say that one's about 95% healed. Okay, this is a picture of a laryngectomy and laryngeal reconstruction. Picture on the left, I just added that because it's cool. That's a picture of it intraoperatively, what it looks like. And then there on the right, that's what you'll see post-operatively. That's the flap that we're checking. It's nice and healthy. It looks really good. All right, so this one's kind of cool. This is another picture of a laryngectomy. Sometimes you'll see these exposed muscle flaps that will come out of the OR, excuse me, with a xeroform bolster over their neck. And you're like, how the heck is this thing ever going to look like a normal neck? I used to wonder this myself. What do we do about this? Like, this wants to walk around with raw meat on their neck, right? So this picture here, this is a picture of one of those exposed muscle flaps. They're in the middle. So we typically will take the Xeroform bolster off prior to patient discharge. And then we'll just instruct the patient to apply tons and tons and tons of Vaseline. Eventually it heals up really nicely. It all kind of granulates in and will eventually end up looking like this patient here on the left. This is this, I think all the same patient, but that one there on the, or excuse me, on the right, it's I would say almost completely healed. He could probably stand to use a little more Vaseline, but you can see that his neck looks essentially normal except for the stoma. So that's what a exposed muscle flap eventually ends up looking like. Okay, so tracheostomy, this is done in combination with a lot of procedures that you'll see. One of the big indications for tracheostomy, the biggest one in generally all cases, an airway obstruction of some kind. So either tumor, stenosis, swelling, clots. You'll see it in our surgeries a lot. It's a temporary tracheostomy tube, knowing that the oral cavity is going to swell so much. So it's placed as a prevention at the time of surgery to prevent any like airway complications post-operatively. So we'll place the tracheostomy tube. So like I said, it might be permanent. If it's like indications for like a permanent trach would be things like vocal cord paralysis, that's generally permanent or at least very long-term, congenital abnormalities, neurologic reasons for a trach, failure to wean from a ventilator, you know, it all kind of depends, but those are reasons for more of a long-term trach. In the interest of this presentation, and you know, you'll see a lot more temporary tracheostomy tubes. So post-operatively, you'll get a chest x-ray to confirm placement of the tube. We're going to check for crepitus. You can check for airflow via the trach. If you feel good air movement when the patient exhales, you can be assured that it's likely in the correct place. When you suction, you're able to easily pass the suction catheter through the trach tube. When you suction, secretions coming out look like tracheal secretions. So those are good ways to know that the trach is in place. Post-operatively, we recommend suctioning at least every 4 hours, more often if needed. And then once they're up on the floor, it's usually about, you know, depending on the indication for the trach, a 3 to 7 day length of stay. Typically, they'll come out of the OR with a cuffed trach in place. The cuffed trach is there so that for one, we keep the cuff up for overnight on post-op day 0 to prevent secretions from going down the wrong pipe, to prevent aspiration. But we deflate it on post-op day 1. Or if they need to go back on a ventilator, they'll have to have the cuff trach in place. But we generally change our trachs on post-op day 3 to 5 to a cuffless trach. It's a lot more comfortable for the patient. It's the next step towards getting the trach out. You can cap it and they can start to vocalize around the trach. And then sometimes we decannulate patients. We have the goal to try to decannulate if we can prior to leaving the hospital. A lot of the smaller cases, like the hemiglossectomies, sometimes they'll get decannulated before leaving the hospital. The larger ones, like the total glossectomies, they generally need longer and they'll go home with a trach. So these are some pictures. You'll see a lot of times they'll come out with a cuffed Shiley. These are kind of, I got to update these pictures because U of M has updated our stock. We don't have these anymore. When I made this presentation, you made this slide a couple of years ago, this is what they looked like, but I got to update these pictures. But the idea, the concept is generally the same. We have cuffed Shileys and cuffless Shileys. We have metal Jackson trachs. We still have them. We don't use them as often anymore, but there are other options. The metal Jackson is a little more low profile. It's pretty smooth, but we stopped using those a while back. We can use them if we want to. A lot of SARS don't take them. If a patient needs an MRI, you have to change it, but it's an option as well. Okay, laryngectomy. The big thing I just want to say about this is that, how much time do I have? Am I done? Okay. All right. I'm sorry. I'm like talking.
People on Zoom.
Okay,
so
honestly, I'm talking longer than I thought I was gonna be talking. I get going and then I'm like, well, okay. All right, laryngectomy. Big thing to know about this. A lot of I will hear so many times a patient with a laryngectomy, their tracheostomy tube, you know, it's not laryngectomy, tracheostomy. This is another topic I can go into. A laryngectomy is a permanent airway. The trachea is cut and sewn to the anterior neck. Once the laryngectomy is there, it is a permanent airway. There's no reversal. You're not going to get decannulated. You're breathing through your neck forever. You are completely ventilating only through the hole in the neck. So if the patient requires supplemental oxygen or needs an emergency airway, it all needs to come through the hole in the neck. That's just a really important thing to know. I've seen in this hospital and patients coming from outside hospitals, nasal cannulas on these patients. And it's like, this is like going to be like my marker of like, by the time I retire, if like like this is going to be my platform to stand on is a laryngectomy. You are breathing only through your neck. You are a neck breather. So it's just a big thing to know. The other thing is the tube that is in the neck of a laryngectomy that comes out of the OR, it's called a Blomsinger tube. It's not a trach. It's a silicone tube that's an airway stent. If this tube comes out, you are not going to lose the airway like you might with a trach. The airway is sewn to the anterior neck. It's not going anywhere. With that said, if the tube comes out, depending on if the patient has a bulky flap reconstruction, the flap might, occlude the airway. So you want to be really careful about that. And if the tube is not, consistently not in place, you could end up with airway stenosis over time, that might require a stoma dilation. But generally speaking, if this tube comes out, the patient will still be able to breathe just fine. So that's my spiel about Blomsinger tubes. Back to the laryngectomy. So the indications for this, so you'll see it a lot of times in laryngeal cancer. The patient needs a total laryngectomy due to cancer at the larynx. The other time that you'll see it is that the patient has had needs a larger resection, like from the base of the tongue or the hypopharynx, where removing cancer at that primary site will put the patient at such high risk for aspiration. They might do a laryngectomy at the time, knowing that the patient would have a dysfunctional larynx postoperatively. So that's another time you'll see it. And the last time you might see it is for a dysfunctional larynx, which sometimes patient goes through radiation. And I think this is so sad when you go all the way through radiation to treat your cancer and your cancer is completely gone, but the radiation or a complication, whatever down the road has left you with a larynx that doesn't function and you have chronic aspiration. And so we'll have patients, sometimes they've been, hospitalized with pneumonia, or they've had recurrent pneumonia 7 times in the last year because they've aspirated so many times. They come in and they get a laryngectomy and it's a big surgery, but it ends up giving them much better quality of life because down the road, you'll still be able to eat and drink normally and you'll breathe normally and you won't aspirate and you can live a very, very good quality of life with a laryngectomy. So postoperatively, these patients, we always consult SLP on these patients postoperatively. Initially, they're just seen, we have a really good inpatient speech therapist. She works specifically with our patients and she's wonderful. She works with them on using a heat moisture exchange device in the hospital. It's kind of like a little filter and it provides humidification directly to the stoma. Having humidification and doing frequent suctioning on these patients is really important. This is their only airway. So if it gets clogged or occluded, they're not going to be able to breathe. So even more so than with the tracheostomies, like you really, really, really got to make sure that their airway is clear because there's no reserve from above if the airway becomes occluded. So we preach frequent suctioning. The nurses are really good about that up on the floor and then teaching the patients how to do it and take care of themselves at home. This is a picture. This is also kind of, we still carry these Blomsinger tubes here in the hospital. This is actually somewhat of an outdated picture. We use a new brand in health, Provox laryngectomy tubes. Those ones are a little nicer. I like them better because you can attach the HME directly onto the device. And then this little picture here on the right, I just like this little graphic. It's very simple, but it shows the upper airway anatomy pre-laryngectomy as well as post-laryngectomy. You can see that, the esophagus remains the same, the food tube is the same, but here on the right, post-laryngectomy, the trachea is cut and sewn to the anterior neck. I've kind of talked about this a little bit, but flap checks, incision care, JP drain care, oral care, suctioning, those are like the mainstays of the inpatient hospitalization. The nurses do a really good job teaching the patients and family how to take care of their new airway, their feeding tube, their incisions and their drains to get them ready to go home. we always watch out for medical complications, surgical complications, and we manage that. But generally a length of stay for our free flat patients is about 4 to 7 days, kind of depending on their comfort level, their support system, who they've got at home, and how they're doing with all of their care. We work really closely. Like I said, we have a lot of support with physical therapy, occupational therapy. We have a wonderful inpatient social worker that helps us. A lot of our patients have really poor social situations that make going home a big challenge. I think on our service, especially, a lot of these people, they come from so far away, they come from limited means, they have limited support at home. So those are all things that we think about when we're discharging them, whether they can go to like a rehab or whether they're planning to go home. So we work really closely with all of our other colleagues. So discharge planning is a big thing. We try to have our patients seen by a social worker preoperatively. We've recently been kind of cut back on our pre-op social work. We'll see how this rolls out. We're going to try to get her back and do some things because she was really great. But we start post-op day 1, talking about what the patient's going to need to discharge home. Discharge planning for these patients takes several days. We have a lot of challenges based on insurance and geographic location, or affected in all realms. A lot of these rehabs that patients, we used to send them to all the time, they have limited staffing and limited availability to be able to accept our patients. Depends on their insurance. There is also limited visiting nurses in the community now based on patients' geographic location and insurance. And it's just kind of the state of the world right now, unfortunately. But we try to set them up with as good of a support system as we can for discharge home. We always think about too, what are their needs for discharge? Our case manager sets them up with suction equipment, wound care supplies, tube feeding supplies, whatever else they need. And we kind of go from there. It's much better now, if you ask me, that we can have family members come in to do teaching with the patients before they leave the hospital. It was a real struggle during COVID when we were limited on the visitor policy because the patient's family members couldn't come in. They could come in maybe once during their hospitalization and then again once on the day of discharge. And ideally, this is repetitive teaching that happens every day until they leave the hospital. So post-hospital care, our flat patients, so if they go home, they will do a video visit with Marie and myself, usually about 24 to 72 hours or so after discharge. Purpose of that visit is for us to just check in and then make sure that they've adjusted well to going home. We make sure they got all their supplies, that they're doing everything in their discharge instructions, and that they're doing okay. And then they'll come back and they'll see the surgeon in the clinic, usually about a week after surgery. And at that time, they'll work with speech as well, to work on swallowing and increase their oral intake if it's appropriate at that time, and kind of start to work on techniques for speaking as well. And then by then, generally the pathology report has come back, and then we can make plans about, do they need further treatment? Do they need adjuvant radiation or chemotherapy? And then they can kind of make a plan from there. Okay, these are some additional resources that I think are pretty good. I'm going to put in a plug for SOHN. That's the Society of Otolaryngology Head and Neck Nurses. We have a local Southeast Michigan chapter. We meet once every other month. If anyone's ever interested, we're always happy to have people tag along. We talk about different topics in otolaryngology that, might be interesting to those in the group. And it's a good way to network. There's a few nurses from here, and then there's some from Henry Ford and the VA that join in as well. It's usually via Zoom, but now that COVID's winding down, we're going to start to meet back in person a little bit. And then the American Academy of Oto Head and Neck Surgery, that's kind of the big organization in Oto. ENTnet.org is their website. They've got a lot of resources out there if you ever want to look into any of this further. And that's my little boy. So I'm happy to take any questions or talk about anything you like.
So just to clarify, for our laryngectomy
Yeah.
patients, we should only be given oxygen via trach mask with humidification.
Yes. Yep. Only via the neck. Yep. If you put it on their nose, they're not going to get anything. You're going to wonder why that their oxygen is still 82. Yes. Yep. Definitely. Okay. Happy to come back if you ever want to talk about any of this, anything more specifically. I try to just be a vague overview for all of you, but I appreciate you having me come talk. Great. Thanks so much. Yeah, no problem. If you want, if it's helpful, if you want, I can send you like a PDF or if you want it of the presentation or whatever. But
I can
you can
probably,
probably save it or actually save it.
Caitlin, thank you very
Yeah.
much.
You're welcome.
Very
Thanks so
informative.
much.
Yeah, it's great.
Yeah, thanks.